Our next two speakers, Dr. Kovelamudi and Dr. Long. Dr. Kovelamudi is going to talk to us about heart imaging. She is an assistant professor of cardiovascular medicine here at the University of Kansas. She earned her medical degree from Gandhi Medical Center and Hospital in 2010 and completed both her internal medicine residency and cardiology fellowship at the University of Arkansas. She's board certified in both cardiovascular disease and internal medicine. Dr. Long is certified by the American Board of Psychiatry and Neurology. She earned her medical degree from the University of Kansas and completed her residency at the University of Iowa. Dr. Long's practice is focused on helping her patients achieve the highest possible quality of life, and Dr. Long will be talking about depression and anxiety. So, Dr. Kovelamudi, I will turn it over to you to discussion of cardiac imaging.
Thank you. Can everyone hear me okay?
You sound great.
And can everybody see my slides okay?
Yeah, the slides look good.
Great. So I will talk about the imaging of heart disease in women. These are my objectives to recognize gender-specific anatomic and physiological differences that impact the choice and interpretation of cardiac imaging, to identify conditions that have a higher prevalence in women where it pertains to cardiovascular disease, and to talk about the imaging modalities for these conditions in particular, and to describe the appropriate indications for cardiac imaging and select the modalities that are best suited to your patient. To start with, the heart is a challenging organ to image, predominantly because it's always moving. So this is trying to image an organ that is moving somewhere between 60 to 100 times a minute, sometimes faster. That brings with it its own set of challenges. In addition to this, women have a particular set of challenges because primarily the presence of breast tissue and sometimes because of the presence of breast implants. There was a reasonably large study with about 400 women that showed that women with breast implants who underwent stress testing had higher adjusted rates of cardiac catheterization, but lower rates of actual intervention, which means that they possibly had higher false positive rates of stress testing. And as Dr. Nupane alluded to in his earlier talk, they seem to also require a smaller carcinogenic insult than men do. Women, depending on chest geometry and breast size, tend to absorb up to 30% more radiation, and a single coronary CT angiogram can increase the lifetime excess relative risk for breast cancer in women by up to 1.4 to 2.6%, and that varies a little bit depending on age. So this picture briefly demonstrates why imaging in women, particularly the SPECT imaging and echocardiograms, are slightly more challenging than they are in men. If you can follow the line that is indicated by the three arrows in the bottom left corner, that is the breast shadow covering at least part of the cardiac myocardial circumference. And when we take pictures, we are trying to see how bright the heart appears on rest and at stress. And sometimes, because of this breast shadow, it can appear like there's a falsely decreased uptake in one part of the heart. And that can be considered a reversible defect in stress testing, but that is a false positive test because this decrease in uptake is only perceived by the camera because of the presence of breast shadow. The picture on the right is what it looks like when you try to do an echocardiogram with standard views on somebody with a breast implant. There's obviously a large shadow that covers most of the left ventricular cavity. And so we end up having to go off axis for our images, and that can sometimes affect how these images are processed and how they are evaluated. What anatomical differences as far as the heart goes change how we image the heart? Women have smaller epicardial coronaries. This is adjusted for age, BMI, body surface area, and LV mass. And so when we do coronary CTAs on these women, the distal coronary arteries become very challenging to image because the spatial resolution of the CT itself is not up to keeping up with how tiny those blood vessels are. Women also have thinner myocardial walls, and this makes the evaluation of non-transmural ischemia in particular challenging by CMR, and I'll go over this in detail in the following slides. There's also a difference in what kind of ischemic heart disease women have. They have less calcified lesions, more non-obstructive plaque. There's a higher prevalence of microvascular disease, and there's also a higher prevalence of single vessel disease in women. What are the physiological differences that can sometimes change both the imaging as well as the risk factors for cardiovascular disease in women? So, estrogen is known to cause a lower vasomotor tone, and it also actually causes some false positive ECG changes because it has some molecular similarities to digitalis. Women attain less exercise stress that is diagnostic when compared to men, and they also have less exercise induced angina. And both these put together actually sometimes give false negative exercise treadmill stress tests because we can take the angina as well as the heart rate into consideration when we're assessing the risk on a treadmill stress test. When you do a PET scan, we know that women have higher coronary blood flow, both at rest and at peak stress. So the higher coronary blood flow and the fact that women have smaller arteries puts a lot more endothelial shear stress. So it's a smaller artery trying to take a lot more blood flow, and this can sometimes increase the susceptibility to atherosclerotic disease. Women also tend to have a slight increase in cardiovascular disease if they have premature menopause, which can be caused due to cancer therapies or because they underwent a salpingo-oophorectomy. And a few considerations in pregnancy. Transthoracic echocardiograms and MRs, which is MRI, is preferred in pregnancy primarily because they are non-radiation modalities. The fetal exposure for all cardiac imaging modalities, even the ones that involve CT and radiation, is actually below 50 milligray, which is considered to be the cutoff for deleterious effects on the fetus. However, when we take into account the cumulative radiation, we obviously want to keep it as minimal as possible. The use of contrast, and which is either iodinated or gadolinium based, is not well studied in human fetuses for obvious reasons. So they are right now classified as category B and C agents. And newborns that have any exposure to iodinated contrast in utero are often screened for hypothyroidism. So this is the average radiation exposure from all cardiac modalities to the fetus. As you can see, PET-CT has the highest radiation dose. None of these for a single study would be considered to cause any fetal effects. However, whenever we do PET-CT, et cetera, and if it is positive, then it's followed up by some kind of fluoroscopic radiation in form of a cath. And so it adds up. So obviously we want to use any modality that confers zero radiation in pregnant women. When you order an echo on a pregnant lady, these are the changes that are normal, physiological, and expected. There's an increase in cardiac output, stroke volume, and decrease in peripheral vascular resistance, because of which there is a generalized dilation of almost all cardiac chambers. The left and right atria dilate, the right ventricle and the left ventricle dilate, and the myocardial mass increases. So when you order an echocardiogram on a pregnant woman and you see mild right or left ventricular dilation or atrial dilation, that's normal to be expected and not much to be concerned about unless the patient is significantly symptomatic. Aortic root imaging on an echo is not always the greatest, but if there's a very rapid increase during the duration of the pregnancy, then they should undergo further imaging with possibly a CMR. This slide basically sums up everything that the first slide said about what the specific risk factors for women are, what the different phenotypic atherosclerotic disease they can have, as well as what is basically the difference in sex-based anatomy and physiology and how it affects what imaging we can perform. Mainly to note here, one is that because of the smaller size of coronary arteries and the left ventricle in general, we have to be a little careful about the imaging modalities we choose. And the women of childbearing age need to be a little bit cautious about what imaging modalities use for their heart. And over a period of time, the cumulative radiation does add up and increase the risk of cancer. So we have to be cautious with those imaging modalities as well. I'll briefly go over the conditions that are more commonly occurring in women and what imaging is appropriate for these conditions. So coronary microvascular dysfunction, ischemia with no obstructive coronary artery disease, and myocardial infarction with non-obstructive coronary artery disease somewhat all fall into one broad spectrum of women that have symptoms of ischemia, but no gross epicardial or 90% or 80% stenosis to account for it. Women also are most of the cases of spontaneous coronary artery dissection. They have a higher incidence of stress-induced cardiomyopathy and obviously peripartum cardiomyopathy. So what is microvascular dysfunction? It can involve either the epicardial microvasculature or the endocardial microvasculature, and it can involve either endothelium or there's sometimes non-endothelial dysfunction as well. It happens because there is a decrease in the size of epicardial vessels. They can have increased stiffness and fibrosis, and they can have smooth muscle dysfunction. How do we diagnose this? It's basically functionally assessing the blood flow that goes through each coronary territory. The gold standard is an invasive test, but we do have several non-invasive modalities that I'll talk about. So this is basically microvascular dysfunction, which is basically, if you look at the PET images on the bottom right, the perfusion looks okay. Everything is lit up. It looks like the whole heart is being supplied with blood appropriately. But when you look at the flow reserves, which are the numbers at the very bottom of your screen on the right, they are all below 2. So that means that this patient, although has blood supply to each territory in her heart, has decreased blood supply with stress on a more generalized basis. It's not accounting for any one coronary territory. It doesn't mean that there's a significant obstructive plaque, but it does mean that at peak stress, this person's heart is getting lesser blood than it should. In a large study, and this was almost 10,000 patients, 58.4% of patients that underwent angiography had non-obstructive coronary artery disease. And by far, female sex was the strongest predictor of non-obstructive disease. To grossly interpret this, you do an angiogram in a woman that has a positive stress test, you will more likely than men get no significant obstruction on the angiogram. But that is not to say that they don't have coronary disease. That is just to say that they don't have large or epicardial blood vessel disease that can explain their symptoms. So what do you do next? The preferred modality to diagnose microvascular dysfunction is cardiac PET and CMR. Cardiac PET is the most widely available and most validated tool that we have. It carries a prognostic value. If the PET is normal, then the risk of future adverse coronary events is very low. And it also carries with it the benefit of not using iodinated contrast or gadolinium contrast, so it can safely be used in patients that have renal dysfunction. In patients where cardiac PET is not an option, we can use CMR imaging, although this is more expensive, not as well validated, and it can be slightly harder for the patient themselves to tolerate because it requires a very long exam. You have to stay prone and still the entire time. You have to stay supine and still the entire time, and you have to frequently hold your breath for about 15 seconds at a time. The definitive way to diagnose microvascular dysfunction is to do an invasive coronary test. Obviously, this has associated radiation exposure, radiation risk of contrast-induced nephropathy, and it's an invasive procedure, so always requires a discussion with the patient about the risk and benefit and potential bleeding complications, etc. We use mostly three drugs to assess coronary vasoreactivity as well as diagnose any endothelial dysfunction, those being adenosine, acetylcholine, and nitroglycerin. So this is the current guidelines, so about 2021 guidelines on what to do in patients that have women that have symptomatic, stable ischemic heart disease. If they are low risk patients, and the risk can be assessed based off multiple cardiovascular risk calculators, which I'll go over in a bit. If they're low risk patients, you can get away with exercise stress testing alone, that is no imaging, or just exercise stress echocardiography. And in these patients, you can also do coronary artery calcium scoring. If these patients have an intermediate to high risk, then current guidelines say you can do either a CT angiogram or you can do functional stress testing with a SPECT or a PET. Who is a better candidate for a CT angiogram? Patients that have no significant calcification in their heart, that have had an equivocal or mildly abnormal stress test in the past, and those that don't have a risk of iodinated contrast. There's a small subset of patients that don't do well on functional testing as well, if they have severe valvular dysfunction or if they have significant bronchospasm. You don't really use regadenoson in these patients, so we prefer CTAs in these patients. The rest of the population do fairly well with functional stress testing. The presence of significant coronary calcification, so if you got a coronary artery calcium score and you have a very high score, those patients, the CTAs are less validated, so we prefer functional testing in these patients. So what is myocardial infarction with no obstructive coronary artery disease? This is an interesting entity where a woman comes in with an acute coronary syndrome. So she has chest pain, she has all the traditional ECG changes, she can have just as much of a troponin elevation as patients that present with a true myocardial infarction. So for all intents and purposes, it clinically presents as an MI. But when you do an angiogram in these patients, there is no obstructive disease, there is no significant coronary blockage that can account for their presentation. Why does this happen? It can happen because they have embolism, it can happen because of vasospasm, or it can happen because of stress-induced cardiomyopathy. So what is coronary thromboembolism? It is the presence of a stable plaque. So they have 30, 40% stenosis, and the endothelium that is covering that plaque ruptures. And when you have plaque rupture, it is a nidus for clot formation. So they go from about a 30, 40% stenosis to almost immediately a 90 to 100% occlusion of that blood vessel. And that plaque and that embolus, the thrombus can eventually embolize. So when they present with the infarction, that thrombus is actively occluding their coronaries, but by the time we get them onto a table and do their angiogram, the thrombus has already broken off and embolized, and we no longer visualize it. The best thing to do for these patients after angiography is to do a CMR, because it can give you a diagnosis of what's happening and help with therapeutic strategies as well. What is spontaneous coronary artery dissection? 80% of these cases occur in women, and a large proportion of them, unfortunately, happen in the peripartum period. About a quarter of them happen in the peripartum period. This is a sudden separation between the layers of a coronary artery wall, and this creates a flap and intramural hematoma causing acute myocardial ischemia. The unfortunate part of SCAD is it presents in a young, healthy woman without any risk factors. So women are in their 30s or 40s, they've never smoked, they've never been diagnosed with hypertension, diabetes, or hyperlipidemia, and they present with an MI. And this is a brief video explanation of what happens. So these are normal coronary arteries when they start off, but unfortunately there's an intimal tear. And when you have that tear, blood goes in between the layers of the heart, and that flap eventually seals off all blood supply to the heart. And so these patients, even though they don't have any underlying coronary artery disease, can present with an MI. And in SCAD, the diagnosis of choice is a coronary angiogram. We very rarely intervene on these patients because long term, we just choose to monitor and treat with conservative management. SCAD is associated with several extracoronary vascular abnormalities, fibromuscular dysplasia, cerebral aneurysms. So patients that have spontaneous coronary artery dissection, once diagnosed on a coronary angiogram, we tend to image them essentially from head to toe and make sure they have no other arterial malformations. Briefly go over the other conditions that are sort of elevated risk in women. Stress-induced cardiomyopathy is probably the condition that has most female preponderance. Almost all cases are women, very few tend to be men. And the echocardiography and CMR findings on this condition are very specific to stress-induced cardiomyopathy. Sarcoidosis and other infiltrative diseases do also have a slight female preponderance, although sarcoidosis probably most of all of them. And the diagnosis for this as well is either a cardiac MRI or a PET. And as Dr. Templeton had talked about, inflammatory conditions are known to be associated with worse cardiovascular outcomes, specifically in the case of rheumatoid arthritis and SLE. The chronic inflammation, we think, causes a preponderance to both coronary and left ventricular myocardial dysfunction. So what is Takotsubo or stress-induced cardiomyopathy? Takotsubo is actually the Japanese name for the octopus trapping pot. And it presents much like a myocardial infarction would, with chest pain, shortness of breath, sometimes cardiogenic shock. And the ECG and labs are also similar to what you would see with a myocardial infarction. All these patients eventually get a coronary angiogram, and their anatomy is almost always found to be normal or minimally obstructive. 8% of women, so almost 1 in 12 women that present with an acute coronary syndrome, are found to have Takotsubo's cardiomyopathy. And the single most important test to do in these women is a CMR, because if you have delayed myocardial enhancement, this detects the presence of a myocardial infarction, and it allows differentiation for these two entities. So did the patient truly have stress-induced cardiomyopathy versus did they have MINOCA, which is the myocardial infarction with non-obstructive coronary artery disease, which is a different entity and requires different treatment. So these are basically a few of the pictures that we get in patients with stress-induced cardiomyopathy. Picture B is the trapping pot in question. Picture A is the left ventriculogram that we do when we do coronary angiography. And you can see that the base of the heart is contracting reasonably well and the apex balloons out. The echocardiogram similarly has preserved basal contractility. So the basal walls are moving reasonably well, but as you can tell, the apex doesn't really do much. On the top right are pictures of a cardiac MRI performed in patients with Takotsubo's, and you can see even on the MRI cine pictures between picture A and B, in systole, the apex doesn't contract as much as the base of the heart. The bottom right picture is an unfortunate complication of Takotsubo's and sometimes even normal ischemic cardiomyopathy, which is the formation of a large left ventricular apical thrombus. If you have a dyskinetic or akinetic apex, blood tends to clot there and patients form left ventricular thrombi. Briefly, I'll talk about coronary artery calcium scoring. This is a great test to use in asymptomatic intermediate risk patients. So intermediate risk patients are patients that fall somewhere in between 5 to 20% on the ASCVD risk score. And this is a great risk stratification tool that we can use to assess their benefit from statin therapy. It's also a good prognostic tool. If you have absolutely no coronary artery calcium, then your risk of major adverse cardiovascular events is less than 1%. 1 to 99 Agatston units is mild disease, 100 to 300 is moderate, 301 to 999 is severe, and over 1,000 is very severe or extensive disease. So in this classification, patients in the middle two rows. So if you fall between 5 to 20%, these are the patients in whom coronary artery calcification can either push you up or down on the risk stratification scores and tell you whether or not you would benefit from statin therapy. So for example, this is the MESA calculator, the multi-ethnic study of atherosclerosis calculator, which takes into account coronary artery calcification. So your basic ASCVD risk calculator does not. So when you have a patient that falls in the intermediate risk in that score, you do a coronary artery calcium score in those patients, and it can tell you whether or not they truly need a statin. At KU, we're very lucky. We have funding from KC Current, and all women who are 40 and above and have risk factors can actually get a free cardio score. And we have a very, very lovely and well-established system that I like, which is the women come in, they get their cardio score, they get preliminary results, they sit down and talk to our lovely nurse coordinator the same day and have a discussion about risk factor reduction, lipid optimization, and appropriate referrals are made the same day. So exercise stress testing. This is ECG only exercise stress testing. And long story short, this is not a preferred modality if you truly suspect coronary artery disease in women. And this is why. So while the top picture is what we would like to see in a traditional exercise stress test, the bottom picture is what we usually get. Especially in women, especially because of the presence of breast tissue, we get a lot of artifact on ECGs. And so we end up having non-diagnostic tests. There are a few things that we can do to help this. We can use bicycles or other exercise modalities. And one of our colleagues is actually working on a specific bra that is designed to help women tolerate the test better, but also to get more diagnostic ECG tracings. So this is the test that is most commonly ordered. This is the SPECT MPI. This has reasonable predictive value. However, in women, again, this is the test that is most prone to breast artifact. And this is on the right, the various SPECT cameras. At KU, we use the D-SPECT camera. And you can see why this test is so prone to breast artifact is because all the cameras are essentially in front of you. So if you have a significant portion of breast shadow that switches in between pictures. So for example, on the stress images on the right, you see a lot of purple on the LAD territory, and it goes away at rest. This is all because in stress, this woman's breast decided to shift over the LAD territory and caused a false artifact. And when we repositioned the breast in the second set of pictures, that artifact resolved. So this is prone to a lot of false positive tests, which is why PET is preferred. PET has higher spatial resolution, improved diagnostic accuracy. It has the benefit of CT attenuation correction. And the best advantage that PET gives over SPECT is that it gives you numbers. It tells you how much blood flow there is in each specific coronary artery territory, but also tells you how much flow reserve these women have. And so it helps us diagnose not only ischemic heart disease, but also helps us diagnose diastolic dysfunction, any kind of infiltrative disease, etc. And so this is a example of a SPECT picture. This woman had normal perfusion. If you look at the two yellow circles, those are polar maps that tell you that blood flow is somewhat equal at rest and at stress. But when you look at the red arrow, it's pointing to what her flow reserve is much, much lower than what we expect it to be. It's only 1.1. And when this woman underwent angiography, you could see that her left main had significant stenosis. So the reason for essentially normal perfusion is that when she was stressed, blood flow dropped equally to all coronary territories. So we didn't detect a specific difference for one blood vessel. So CTA, obviously very high diagnostic accuracy, though slightly lesser so in women. I realize I'm almost at the end of my time, so I'll rush through the last few slides. But in CTA, the benefit that we have is twofold. One, we obviously get an anatomic description of what we think is the blockage, but also it tells us if the patient has high risk plaque. So what is high risk plaque? If it has low attenuation, if there's spotty calcification, or the napkin ring sign. And these can also help tell you whether your patient is at higher or low risk of developing an MI in the future. The other benefit with CTA is we can do essentially CFR, which is FFR, which is basically assessing physiological drops in blood pressure across a stenosis in question. So if you look at the top right picture, the CT-FFR on this patient is 0.63, which is a ratio of pressure in the left main to the distal LAD, and it correlates very well with the coronary angiogram. The other benefit with CTs is that they can tell you non-atherosclerotic causes for chest pain. So patients that have anomalous coronary arteries or patients that have myocardial bridges, as pointed out by the two pictures on the bottom left. CMR. This is probably the modality with the least radiation, the highest accuracy, and the most bang for your buck. It can diagnose almost every single cardiovascular condition there is. It can diagnose ischemia, infiltrative disorders, the etiology of cardiomyopathy, valvular dysfunction, and it can give you a number, which is, it will tell you exactly how bad the aortic regurgitation is, or how much myocardium is involved in a particular condition, et cetera, et cetera. And so basically, if you look at the enhancement, it can be in one part of the heart, as it is in A, indicating that this person had a myocardial infarction affecting that particular part of the heart because of the LAD being blocked off. As opposed to in picture B, you see a sort of lateral wall having non-coronary distribution in enhancement, which basically means that this person has abnormal myocardium, but it doesn't belong to any one coronary territory in particular, and it's non-transmural, so it probably wasn't an infarct. And the bottom is Takotsubo, which we already talked about. This is the other beautiful thing about CMR is we can diagnose bicuspid valves, but more importantly, we can see exactly where the regurgitant jet is going. We can see what its effects on the aorta are. And this is a very useful tool, especially in pregnant women, to monitor aortopathies. This slide basically sums up essentially what we talked about, which is the benefit and risk of each single individual modality as it pertains to women. I hope we can take away from this that PET and CMR are our most useful modalities, but we only want to choose to use them in the appropriate women. So I'll briefly, and these are the multiple risk calculators that are used to assess your risk for surgery, for atherosclerotic disease. Currently, we use the ASCVD risk calculator, and it can be sort of reiterated with a MESA score if you're able to add a coronary artery calcium score. All of these conditions in the right column can also help you understand if a patient truly needs cardiac testing or not. The presence of any of these conditions should prompt immediate imaging and further follow-up. This is the last most busy slide, but I'll leave you with just the green parts. So in symptomatic patients that have enough risk factors, the ACC/AHA guidelines say that almost any test is kind of appropriate, which is the green. They do not recommend coronary artery calcium scoring really in symptomatic women. In asymptomatic patients, it is the converse. Usually the most appropriate thing to do is not test at all. And if you do test, it's not really functional testing that they recommend. It's only a coronary artery calcium score that will help you understand whether or not a patient will benefit from statin therapy. Thank you. I apologize for going over my time, and I'll be available for questions at the end of the next session.
Okay.